You ready? Yes. Okay. Okay, everybody, we're going to go ahead and get started. I'll be chairing today. Our Budget and Finance Chair, Dr. Musatif, is out today, so I'll be chairing in her stead. So, okay. Good afternoon. Today is October 22nd, and it is 4:04. As a quorum of the committee is in attendance, I'd like to call to order the meeting of the Central Health Budget and Finance Committee. So the first thing is public communication. Do we have any public communication?
Yes, Chair. We have three people for the 4 p.m.
Okay. And so I'd just like to announce that in order to make it more accessible to community members, we'll hold public communication for the Budget and Finance Committee and the Board of Managers meetings at approximately 5:30. However, we will take public comment right now in order for the public to be able to comment. So, all right.
Perfect. Thank you, Chair. When called upon to speak, please introduce yourself by name before beginning your comments. Also, if your comments will focus on a specific item or issue on the agenda, please indicate the full item number after your introduction. Each speaker will be limited to 3 minutes. Staff will be timing each speaker and will announce when a speaker has reached their time limit. To ensure the efficiency of the meeting, once we have let speakers know they've reached their limit, we will allow 30 more seconds to wrap up their comments before they are muted. Due to the restrictions of the Open Meetings Act, the board may be restricted in discussing any items that are not listed on the agenda for this meeting. The board may choose to set aside any new issues for discussion at a future meeting. Up first, online, we have Joshua Collier. Josh, are you able to unmute?
Yes, and good afternoon, and good afternoon to the Central Health leadership. First of all, thanking you for the labor that you undertake to provide service, especially to those who most need access to healthcare in Travis County. So I was born in Austin and have a long history of advocating for patients, clients, many of whom were recently arrived from outside of our community, many of whom speak many languages, not just Spanish, but French, indigenous languages like Kachi, Kel, or Mam, Burmese, Vietnamese, Korean, Arabic, Pashto. And my concern is a lack of training in language access of all patient-facing staff, front desk people who interact with patients as they arrive. In the case of direct care within Central Health specialty clinics, and also within the enterprise through the work of community care. I've accompanied clients who have received wonderful care and attention from great providers, have access care through MAP, but I'm also aware that there is not a coordinated effort to train the staff so that they have an easier time using interpreters for spoken communication, whether it's ASL or other languages. Also, whether there's substantial support for written translations of written documents. I do have news that they're now translating MAP documents into Vietnamese, Burmese, and Arabic. However, when those forms are filled out in other languages, they will then need to be translated back into English. And so I'm glad to know that Central Health has worked partnering with the Austin Asian Community Health Initiative, ACHI, to help with that. But to me, this is a patient access issue. It is the law. It is still the law under the Title VI of the 1964 Civil Rights Act. And just to remind ourselves and recenter on the fact that the right care at the right time, at the right place, cannot happen if the patient doesn't understand what's happening. It can also lead to certain legal liabilities that could put Central Health in jeopardy. Malpractice, misunderstanding around medication management, not allowing patients to offer an appropriate medical history, and so on and so forth. But I think the thing to center on is that quality of care cannot be provided without this. And no matter how many initiatives you undertake around food access or better workflows or medical improvements, those will not be translated to quality care without the appropriate language access. And so Central Health needs a language access plan, and they also need a language services department or a business department to coordinate this work.
30
Needs
seconds.
to be understood. Thank you. Needs to be understood that Spanish is on par with English in Texas, and there should be significant presence of medical providers who can provide direct service in Spanish. And so recruiting more providers in that language, but also recognizing that there are other languages. Vietnamese is the third most common language. Thank you so much for your time and for considering this. I know that together we can improve patient access and quality of care. Thank you.
Thank you for bringing this to all of our attentions. Thank you.
Chair Kitchen, I don't have a question, just a quick statement if you
Yeah,
around this.
just
if
a
you don't
quick
mind.
statement.
Not
go
to
ahead.
engage discussion
Yeah,
by any
yeah.
means.
Okay,
I just
go
want to acknowledge Mr. Collier, who's been a beacon in the community for my 30 years here. I've seen Joshua around advocating for patients, clients, individuals in need, irrespective of which forum, from Casa Marianela to Dell Medical School, and I'm just really deeply appreciative of this feedback. Thank you.
Thank you. Okay, do we have any other speakers?
Yes, up next we have Corbin Pefanis, who's online. Corbin, are you able to unmute?
Yes, can everyone hear me?
Yes. Yes, we can hear you.
Good afternoon, everyone. My name is Corbin Papanis. I'm a consultant for Adelato Healthcare Ventures, and we represent private hospitals across the state on all matters related to Medicaid reimbursement. First and foremost, I'd like to express my gratitude and appreciation towards Katie Coburn and her team and their role in administering the Travis County LPPF. On behalf of our clients, I'd like to voice support for the 6% proposed mandatory payment rate to be imposed on institutional healthcare providers. The local provider participation fund plays a crucial role in expanding access to care amongst the community's most vulnerable population and allows providers an opportunity to offset a portion of the unreimbursed costs they incur treating Medicaid beneficiaries through a variety of supplemental payment programs. Thank you for the opportunity to speak.
Thank you.
Thank you, Corbin. Up next, we have, let's see, Dr. Tara Greendyke, who's here in person.
Thanks. I'm a rookie. Hi, everybody. I'm Tara Greendyke. I'm a pediatrician and the Director of Child and Adolescent Health for Community Care. Thank you all for having me here today. I just want to start with a quote that I hope if you can keep it in your mind while I'm talking, it'll sort of frame the conversation. And it's a quote by Joy Harjo, the poet laureate. "Children are the rudder of hope." So, as many of you know, community care serves more than 40,000 pediatric patients, roughly a third of our total patient population. Through community care and carousel clinical sites, we serve and include primary care, dental, therapy, and behavioral health services. For years, our teams have worked to meet this demand by stitching together across multiple aging buildings, sites with limited space, insufficient infrastructure, and inadequate parking, delivering primary care with insufficient space to fill in behavioral and mental health needs that our patients simply cannot access elsewhere. This is hard, and it is part of, I think, what contributes to the moral injury and burnout of those who care for these children. Despite these constraints, we've expanded services where we can, but the reality is we've outgrown our facilities, and our stopgap solutions cannot sustain the volume or the complexity of needs that we've seen. Our pediatric practices are at capacity for primary care, mental health, and specialized developmental services. All of these things remain among the biggest unmet needs in our community, especially for the and underinsured. Needs such as autism evaluations are simply out of reach for most of our families. In fact, just this week I found out that there is essentially almost no option for our children that fall into our MAP and MAP basic and uninsured bucket. Families wait months for evaluations for therapies, and in many cases, they sometimes are referred outside the system where there is a breakdown of continuity of care and coordination. So what is our vision? We've been planning for several years to create a modern pediatric and family care hub, a coordinated model that brings together pediatric, women's, and behavioral health services under one roof. The goal is to build on what already works and not to duplicate it, offering families a continuum of care from preconception through adolescence. And this effort is about modernizing our delivery system for children and for families, not about buildings alone. It's a strategic evolution tied to quality, access, and financial sustainability through the enhanced PPS rate. Carousel Pediatrics is a core piece of Community Care's pediatric network. It serves thousands of families and will continue to do so. The hub model is designed to complement and not compete with it, offering space and services that Carousel cannot currently accommodate, especially in behavioral health, specialty pediatrics, and care coordination. Together, these sites will create a stronger, more connected system that better serves our patients and our providers. This initiative is data-driven and community-driven. It reflects years of work by pediatric leaders and frontline clinicians to strategically fill in the gaps. It directly supports Central Health's population health mission and expands access for low-income and Medicaid-covered children. 30% of children are served by community care are MAP and MAP basic. The model also builds training capacity for next generation of pediatric and behavioral health professionals through partnerships with UT Medical, Dell Medical School, and other institutions, including the pediatric residency program based in Pflugerville. Thank you for listening, and I just want to say as a last comment that the best way to build health in our community is to start with our youngest and most vulnerable. Thank you.
Thank you.
Thank you, Dr. Greendyke. Up next, we have Isela Guerra. And this will be our final public communication until 5:30. We have one resident signed up.
Good afternoon, Board. Thank you for having me here today. I wanted to bring to you just some highlights from our Vivir con Ganas Health Expo, which was on September 27th last month. We had a great showing. We had over 465 people in attendance. Online on our YouTube channel, we have had to date over 315 views of that recording. This event, brought forth by Manager Valadez, was a great showing of community support, a cultural celebration, and a connecting of healthcare resources and services to some of our most vulnerable in Travis County. We did connect over 200 people with health screenings and vision screenings, as well as over 100 people who were uninsured or underinsured to the medical access program. Online, we had well over 5.7 million views of our ads and of the services that we were offering. We also were able to help those people in attendance by providing support like childcare. We had over 50 children in childcare for the day, and we even assisted 17 individual members with transportation from our MAP program. The event was a big success. There is a memo in your board packet with more information and with some quotes. But I will say, having been there all day, that it was just so fulfilling seeing the smiles on people's faces, watching them engage with our presenters, and with over 75 Central Health volunteers who were there to make that day possible. So thank you all for your attention to this, and Manager Valadez, thank you once again for your proposal of this wonderful expo.
Thank you, and thank Central Health. And thank my board of members for jointly. Wait, turn on your thing.
Thank you all, and thank Central Health, thank Community Care, and all the sponsors who participated in the event. And thank you to my dear fellow board members who saw fit to support an endeavor like this as a first non-English speaker conferencia. And hopefully we'll be even more successful next year. Thank you.
Yeah, I want to say thank you, Manager Valadez, for leading this effort. And thank you to our wonderful staff who just did an amazing job pulling this off. I really appreciated the opportunity, and I appreciated the fact that it was all in Spanish. It stretched me a bit, and I did have to listen to the translation, but you know, it was awakening some of the Spanish that I thought I knew. But anyway, I thought it was great. I thought it was a really good thing, and so thank you, Manager Valadez, and I'm looking forward to next year. I know y'all will do even more next year.
Yes.
So thank you.
Thank you.
Okay, I believe that's all of our speakers for public communication at this point. So I'm going to move on to the committee agenda. I'd like to take a motion to approve the minutes from the last Budget and Finance. Motion from Manager Mays, second from Manager Valadez. All in favor? Okay, minutes are approved. We'll go on to item number 2, which is to receive the September 2025 financial statements for Central Health. And I think we have Nikki Riley and John Morgan presenting.
Hi, Nikki Riley, Deputy CFO. So this is our September financial statements. We wanted to present this month to you because this is the end of our fiscal year. And while these financial statements are not the final audited financial statements, we have tried to book all of the necessary expenditures and revenues that would go into the monthly financial statements for the board to look at. And so I wanted to go over some of the variances and any questions that you might have. And John is going to help me explain some of the items that might be way over or way under budget that you might question. I'm going to skip the balance sheet and go straight to the sources and uses, which I don't know what page it is in the entire packet, but it's page 6 of the financial statements. I can't see it. But that's it. Yes, that is it. So I did want to kind of go over some of the variances, like I said, but I also wanted to kind of compare that to September of last year as well, and where we are on our direct services and our spend on that. But first, over on revenue, we're at 109% of our budgeted revenue, so we are over. And the main reason of that is due to the other revenue again. We do budget conservatively. We do not want to we do not want to over budget revenue, under budget expenditures, and so we're usually pretty conservative on interest because it's really hard to forecast. And so we were $9 million off on our interest forecast. And then in other revenue, well, that is in other revenue, but also what is in that, I think this was in a prior month, but the $22 million sale of David Powell is in that revenue, and we didn't budget that, but it is revenue this year. So those are the two main things. And then the tobacco settlement, we try to be conservative on that budget as well, so we are a little over on that as well, which is not bad thing to discuss. Any questions on revenue?
Could you speak to the patient revenue line?
Yes. So the patient revenue, and we are kind of just getting this year used to Epic, it coming over to the financial statements, figuring out how to reconcile. In the month of September, we noticed that there were a lot of billings that we had not adjusted, the administrative adjustment. So that adjustment is if you have insurance, you adjust down for what the contract is, and then the rest is either a copay from our MAP and MAP Basic or third party. And so we noticed that in September. That's why it's negative in the month of September. And that the $145,000 then is net of all the adjustments.
Okay. Other questions for her at this point? Manager Valadez?
Is it okay for me to ask about the other financing uses in the second part of that sheet?
Okay, sure.
I'm asking.
Oh,
What does that mean?
other financing
uses,
oh.
and it's
So in the other
that
finance,
61 million?
yes. So that was the $50 million that we put into the capital reserve for Hancock in the fiscal year 25 budget. And then the additional amount, the rest of that amount is the additional emergency reserve for the increased expenses. I think it was 11 million.
Okay, other questions? Anyone? Okay, go
Just
ahead.
a real quick
Ronald.
one, just to level set, the FY 2024 year to date, that's just a comparison for us?
Yes.
Okay, thank you.
Okay. All right, if you want to keep going.
Yes, okay. I want to go over, instead of, these are summarized on this page, so I want to go over to a couple pages, over on the healthcare delivery page, on page 8, yes. So I want to go over primary care, because it's the main reason for the $5 million difference. On the primary care side, we're over budget. This was the additional budget for the additional expense for CUC. We did have some other contracts go over budget. People's Marisos de Cristo, is that how you pronounce that? Went over 300,000. So there is a real demand for primary care. Specialty care, I want to go over that in detail on page 9. But I also wanted to kind of compare it to the percentages from September of last year. So these are pretty good. The 87, in the 80s is a pretty good spend on the budget. Specialty care last year was only 63%. And pharmacy was 78%, and post-acute care was only 71%. And so I feel like we're really figuring out our referrals, being able to contract out and get the patients the help that they need. So those are all third-party healthcare providers. So on direct services, let's go to the very next page.
Could we ask a question on
Of
this
course.
page first? Okay, on the Community Healthcare Initiatives Fund,
Yes.
the 15%, so is this, so it looks like, am I reading this right, that year-to-date we've spent 149,000 out of the million?
Yes, I believe that is mainly a consulting contract that we budgeted for that took a really long time to do the RFP and to get going. Mm-hmm. And it is now, but it was very late in the fiscal year.
Okay, well, this may be a programmatic question that we need to address at some point. I just want to, my question is just, so if we got it, this was for food service, if I'm understanding correctly, and are we projecting to use that million? I mean, do we have a contract? Do we have a contract?
Go ahead.
Do we have a contract in place now?
I think there is a contract in place. I don't think it was executed until pretty late in the fiscal year.
Okay,
And I think that contract's award period will go into next fiscal year, if that
Okay.
answers your question. But
Well,
I
but
don't think the intent, the expectation is that we will have expended the $1 million for FY '25.
Yeah, no, I didn't mean that. I'm sorry. What I meant is that this was for a service that we identified, you know, a high need for, and that's, you know, food is medicine.
Yes,
And,
medically tailored meals, yes, ma'am.
yeah, so I'm just wondering if we're projecting for this year that we're in right now, if we've got a contract in place that we're projecting we'll use the budgeted amount.
I don't know the answer to that, but we're happy to go back and find
Okay,
out
if you
that
could
answer
check
for you.
that for us,
Yes,
that
ma'am.
would be great. Okay, Manager Valadez?
Yes, and thank you for elaborating on the actual contract. It's for food as medicine. It was my understanding that when we first approved this $1 million set aside for healthcare initiatives, it was going to be services that we would authorize y'all to spend for closing disparities and equalizing treatments and, you know, helping our community. But for food as medicine is something different to me. That means something different. And I understand food as medicine. However, I would love to see something like that in a different category, if it's at all possible. I didn't know if anybody
The
else
chi-
felt that way, because I haven't, I guess I'm looking for a definition of what healthcare, aside from food, would be.
Yeah, and Manager Valdez, I might have used the wrong term. I'm not sure. I'll let these guys tell us.
So we can also schedule a presentation from Megan Cermak on the Community Health Initiatives Fund, but everything that John and Nikki have said is accurate. One element is medically tailored meals, which
Okay,
we are
I
referring
understand
to
that.
food as medicine, working with the Capital Area Food Bank and others to make sure that populations, vulnerable populations with certain diagnoses, when they're getting out of the hospital, have the meals. The second area is actually providing the food pharmacy, which is providing food for people that have identified food insecurity at areas like the North Central Clinic and at Southeast Health and Wellness and at a couple of other sites, Hornsby Bend, I think, where we've identified populations that have access to food insecurity. And then the third area is the one that we just entered in. I think we've just entered into an agreement with the provider who is going to be providing food for people experiencing homelessness, also training people experiencing homelessness to cook these meals and provide them in a site, education as well.
I guess what
Yeah.
I'm looking at is the distinction between the provision of what we would normally consider healthcare services for initiatives that we had not normally or would not normally include in our budget. And so I would personally appreciate I guess maybe an itemization, if that's going to be necessary, because I'd like to know the distinction. I understand perfectly food as healthcare, but when we have people that aren't getting their dialysis, or they're not getting their meds, or they're not doing this, to me, that is at least as equally important. And I'd like that to be, I guess, broken down and itemized, if that's at all possible.
Okay, so what I'd suggest, if this works for you, is that we have an agenda item. So if we could make a note to have an upcoming agenda item, it can be on budget and finance, where we can talk about this pot of money and the types of services it's being used for, and the suggestions that Manager Valadez and others might want to make. So would that work?
Absolutely.
Okay.
And we have their 2-year cycles, like John was saying, and
Yep.
so we're entering into the second
Okay,
year of the CHIP, so it's a great planning time
Okay.
to get information about what the next cycle should include.
I appreciate that, and I just want you to be aware of the fact that I'm concerned about that, because, you know, I had a meet suggest something 2 years ago that didn't necessarily get funded, and now we're looking at it, and it could very well easily have come out of this pot of money. So that's why I'd like for clarification for our board and for myself at least.
it sounds like
Thank
a
you.
good conversation to have. Let's put it
I'll be
on
happy to do
another meeting, so thank you. Okay, other questions at this point, or shall we keep going?
I have a quick comment on that.
Okay.
Certainly understand the need to really profoundly discuss CHIP and particularly non-traditional interventions for supporting health outcomes, particularly SDOH. I do want to point out that I remember it being brought up in those community conversations that we had, particularly like frequently, and I remember it coming back as feedback and us discussing it. And I also I do think that exploring that further is going to be a healthy conversation, just given how we've evolved as a board and staff together. And that said, I also wanted to just acknowledge staff for moving forward the initiative. Manager Valadez, that you had mentioned that I didn't hear back on a little while ago. They have been really brilliant and accommodating with moving things forward. So thanks, Chair Kitchen.
Okay, Ronald?
Nikki, this is more of a process budget question. Like, since I understand the contract was signed later in the fiscal year, do you all accrue these expenses, or do you roll them over, or do you zero them out and then there's a budget for it next year? Just trying to get an understanding of that.
We accrue expenditures, actual expenditures, but budgets do not roll over. We don't have an encumbrance system. We don't encumber. And so the budget that is approved is not a rollover of any budget from the previous year.
And when you say actual expenses, if it's a contract that is paid out, then those can be accrued as expenses.
We are full accrual.
Actual expenses.
But they had to have done something, performed the services, or provided the equipment.
To get it accrued.
For us to accrue it,
Yeah.
yes.
Thank you.
Unspent
Question.
funds go into
Okay, hang on.
the beginning balance for the following year. Right. We have a contingency carry forward.
Oh, the contingency,
So
yes.
unspent funds on any of these line items carry forward as a source for the following year's budget through our contingency carry forward.
And carryover is based on a
Fund
financial
balance?
policy that the board has approved.
It's based on really what cash we don't spend, and it carries over to the next year. It goes into the contingency reserve, but it doesn't go into anybody's budget, if that makes sense.
Yeah, and just to follow to the policy, is that a gap issue, or is that like a particular financial policy that you have, that we delegated
Budget doesn't
that
have to be
authority?
gap. We don't budget gap, we
Yeah.
budget modified accrual. And so that is basically the unspent portion of what was in our budget for the previous year, and it adds to or takes away from the contingency reserve.
Yeah, I think I'm asking what the policy authority.
I think I hear you, Manager Rodriguez, and I think that is an opportunity for us to clarify and then make sure we discuss, and ultimately the board chooses and acts on a policy that encompasses the goals and the limitations of how budget and reserves occur, including that element. So it's a good opportunity. We've been talking about developing such a policy, and I think as we get through this next set of hurdles, we will be working on that.
Yeah, no, thank you for the clarity.
Yeah, thank you.
I think we had another question over here.
Yeah, and I think I know the answer, but I'm going to ask it anyway, just for clarity purposes. First of all, let me thank Manager Rodriguez for asking that question, because I had already written those questions and I was going to ask them offline, but
Okay.
I appreciate you asking them. So you, if I understood correctly, you said the unspent dollars go into the contingency reserve, right?
Correct.
Now, here's my question. Do we carry also in this budget a fund balance?
It's kind of the same thing.
Yeah, I figured that, but I want to hear it from you all.
It is.
Okay, all right, okay, thank you.
And I have a follow-up question. So I'm not sure if I understood what you guys were saying, because I think I heard you say that if it's unspent in this year, it goes into the same bucket for next year. Okay?
So most of our contracts are annual contracts.
Right.
And so at the end of the fiscal year, the performance under that contract ends. If there are unspent funds, as we're doing the budget for each year, there's an estimate of our funding that's going to roll over as a source for the budget that you all approve for the following year.
In
But
total.
it is, in total, it is not at a line item. So if we have unspent funds for the Community Healthcare Initiatives Fund, that doesn't mean that next year's budget is automatically going to include.
So it's just swept, basically.
Correct.
That's the term we use with the
It is.
city, it's just swept.
It is swept.
Okay, all right, that was not my understanding, and I must have misunderstood. I thought, but let me ask you this, if a contract, if someone has, or an entity has started to bill, for a particular service, but they didn't get it all billed by the end of the month, or the end of the year, I'm sorry, what happens? Say they have a year project, and they start a bit late. They still need the rest of the dollars, and they're still providing those services. What happens then?
So usually we know that, and
Yeah.
we do put that into next year's budget.
Okay,
And then we accrue into the previous year's budget, the current year budget, any work that they did.
okay,
So they have to perform the service, then they bill us. A lot of times we don't get all invoices, so we estimate. There's a lot of estimates involved in accruing. So that's how that works.
but we don't sweep it, we put it into the next year's budget for that purpose.
We estimate based on what we expect the need to be in the following fiscal year. So if we have, and we'll see that throughout the budget, that we have a lot of services that, as we're standing them up for the first time, as Nikki mentioned, it can take longer to contract than anticipated.
Yeah.
It takes time for those services to ramp up. So as we're preparing the budget every year, we are taking that ramp up into consideration if it's a new service, so that we take our best estimate at what we think a full year's worth of funding is going to be in year 2 in this example. So we account for that ramp up in the proposed budget that comes to you all at the beginning of the year.
Okay,
So-
go
so
ahead.
To clarify, you do not roll over funds from one fiscal year to the other around like this contractual explanation. In other words, there's two flow of funds. You end the fiscal year, you accrue, whatever's left over, you put into the contingency reserve. That's one flow of funds. The second one, if I call it a flow of funds, is you anticipate that contract is going to continue on because the term has bled into the next fiscal year. So therefore you budget for the next year in that particular line item. So there's two flows of funds, or two lines, maybe I'm using the wrong word, but there's a flow to the contingency reserves, and then there's another additional budget item. It's not rolled over.
The only part that I would clarify is the carry forward of unspent funds is not an additional separate pot of money. It is included in the overall revenue estimate for that new fiscal year.
Sure.
So it's not separate. It is estimated as part of the end of year estimate and is incorporated as a revenue source in the new fiscal year budget.
Correct.
Okay, other questions? Okay, you want to keep going?
Okay. Where did I stop? Okay. So that's all I purchased, healthcare services. So I wanted to go ahead and go to the direct services detail page, which is the very next page. And there are some that are under budget that we just haven't been able to hire a provider yet. John can explain that. And then we do have some that are over budget because the need is just so great. But some of the ones that got started very slowly, and some, like neurology, we have not been able to hire a provider yet. The $20,000 right there is to hire a recruiter. And so hopefully next year we'll be able to hire a provider for that. And the ones that got started really late, endo, rheumatology, cardiology, those are the ones that we have not been able to adequately get providers in right from the start of the fiscal year, so that's why they're low. I'll let John speak to the ones that are over budget.
Yeah, I don't have a lot to add from Nikki's comments. You'll see in endocrinology and rheumatology, the budget is relatively smaller than some of the other service lines, and that's because we had a planned implementation in the second part of the fiscal year for those new service lines. Neurology, we have not been able to hire. I'll mention psychiatry as well, is a particularly challenging specialty for us to identify and recruit providers. But largely, these are all services that are within the past 2 years of standing up, and we're, I think, ahead of where we expected to be at this point in the year. As the board adopted the budget resolution for fiscal year 25, we set an encounter goal for these directly provided services at Central Health of about 13,000 encounters in FY25, and we actually closed the fiscal year with over 20,000 patient encounters for this year. So even though we're at 69% of our budget at this point, we're exceeding our services targets for the fiscal year. And every one of these services is still a work in progress to get to scale and to get to stability. The only other one that Nikki alluded to, podiatry being one of the service lines that's over, you'll see that it's also over in the contracted services area. And some of these budgets are reflective of access that's available in the system. So if we have the ability to go out and contract with another provider group, or if community care, for example, can hire another provider in a specialty, that may cause us to go over if that prior year budget was based on the historical volume of services that we've had. So happy to answer questions on any of these, but at this point, we're pretty pleased with the progress. Yes, sir.
ENT's not accommodated for here? I don't see ENT.
ENT is a service line that was not anticipated at the beginning of fiscal year 25. It was one that, and I'll speak to ENT on a subsequent slide, but it's one that was added based on the need for additional in-house capacity. So, yeah, it was not one that had a budget going into the beginning of the year.
So have services begun though with him?
Yes.
The ENT? Okay, good.
Yes.
And could you explain the difference in the patient navigation center cost for the year?
I'm not certain what that is, but we can get back with an answer on that.
Thank you.
Yes, sir.
Manager
You
Valadez?
happen to know what?
I just wanted to say, for comparison purposes, last year, direct services was 47% of budget.
Okay.
And so we've substantially been able to get things off the ground since then.
Okay. Manager Valadez, did you have a question?
Yes, about Patient Navigation Center. It was, since that's a people-heavy, case management, making phone calls, that kind of thing. I understand that, but are the staff people that you all employ to manage those calls? Are they per a diagnosis, I guess, or per area, or is it just
No.
one call center?
Yes.
And those are the people that are handling everybody's phone calls?
Correct.
Yeah, there are a lot of sub-line items
Oh,
that
I know.
roll up into that single patient navigation center line, and we can get you more information on
Number of people
what in
who are doing
particular
that?
is over. I don't think we are over budget in terms of personnel, but this is everything from contracted transportation costs. This is nurse triage for people that are calling in. It's language access and interpretation services, patient appointing, referral management. We can get you additional details. on
That's
where
that's exactly appropriate, and that's one of the things that I would be interested in.
Yes, ma'am.
Okay, because I can see those.
Happy to follow up on that.
I appreciate it. Thank you.
Yes, ma'am.
Okay, if y'all want to keep moving along.
Yes, okay. So that really does it. Well, healthcare operations and support. It is under budget. There's a lot of different departments and services in this line item. From Epic, which is our.
Is this the page we should be looking at, or?
Oh, no.
I think she went back.
Oh, I'm sorry, I went back a
two
page.
slides.
Right there, so I'm on the healthcare operations and support line.
Okay,
So this is all the clinical support, which includes IT, all the infrastructure and expenses of supporting all the clinics. The biomedical equipment is huge on us figuring that out. It's facilities for the clinics. And so there are a lot of people. So a lot of the difference is FTEs, the salaries and benefits, and then vacant FTEs. But then also, we really need to make sure that we have the budget for certain things, like IT services, because we're trying to expand our clinics, and a lot of that is IT services, to be able to put in internet. A lot of things touch IT. And then also facility services. With the CEC, the elevators went down, the cabling was bad. So there were all these issues, and you just never know what you're gonna have. And so we usually put in a pretty substantial budget for facility services. And so that was a little under budget as well. And so it's just a variety of all these support personnel and services that go into running the clinics. And I can get detail on that. It's a lot of different things.
okay. Any questions over here? No, I'll be right back to you.
No problem.
Manager Jones?
As it relates to those facility services, when you look out our plan over the next several years, more facilities going on, being brought online, I think it would be very wise to do exactly what you just said a while ago, is to start building in those type of costs. Because anytime you add those facilities, they're going to be challenging. And so I think that's a wise decision. So I'd like to compliment you all on doing that. But I encourage you to incorporate those in the budget long term at some realistic number for what we expect.
And we have done just that in our forecast that we present. We have built in facility costs. Like I know that we put in a pretty hefty amount for Hancock. That'll be coming online in 26. So yes, we have done that. Thank you.
Okay. Anybody else over here? Okay. Manager Valadez?
I just want to make sure that when we're talking about facility or healthcare operations and support, we are not talking about people. Are we talking about people?
Yes.
In that, okay, then
Lots
to
of
me,
people.
in my head, I need clarification for people. Because support staff, to me, goes under case management, goes under what we had in this other section for patient navigation, all of that. And either, since it's all lumped together and it's not identified by diagnosis or area of expertise, then I would like to see, if it's at all possible, a breakdown. We can have this conversation offline, but I think it would behoove us as a board to start becoming aware of what it costs to run this agency as a people. We do have a people officer, so let the people officer tell us how many people it takes to do what. And
Okay.
take that into consideration. Thank you.
Okay, so I'm hearing a request to come back to us, if y'all make note of that, and at the appropriate time, bring that information back. Okay, if you want to keep going, I want to let us know that we're running about almost half an hour late. So we may want to, that's just for awareness. I don't want to cut down conversation, but just for awareness.
So the only thing left really is the third-party specialty care services.
Okay,
Yeah.
That
And
is,
I'll take this very quickly. So it's
Couple pages more.
slide 11 of the financials. Go forward.
forward 3 pages.
Really just want to make sure that back 1 page. Want to make sure that the board is aware of some of the variances in terms of our contracted specialty care. Again, we try to take advantage of additional capacity partners that want to work with us. There is a combination of things that result in variances to this particular slide. Sometimes it's increasing costs and contracted rates. Sometimes it's additional providers and groups that are joining our network. I'll give you a few examples of some of our cost leaders, or where we are seeing cost increases that are larger than average, are in the areas of anesthesia, oral surgery, and Dr. Martin mentioned earlier, ENT was one of those areas where, by internalizing that service at Central Health, we're able to provide almost twice the volume of care at about half the cost. So we've been very pleased with being able to internalize that service and maintain a very high quality service for our patients. Oral surgery is a cost leader for us in terms of rates, but we've also added 2 new groups in that space, which have increased our spend. So overall, in specialty care, 87% of our budget, we really look to that bottom line number as what we're managing to across our network of providers that's now close to 150 different contracted groups and private practice providers that are providing services to our MAP basic networks.
Okay,
Questions?
all right, we'll wrap this up.
Real quick.
Thank you. Is it feasible to have a projection of anticipated encounters in each of these categories? Is that part of our forecasting in each of these, particular service areas, whether they're contracted or stood up? So the reason I ask is because when we have wide variances like this, and thank you for providing the detail because it's helpful. But when we have wide variances like this, it's also helpful. To me, it would be helpful to have one other dimensional metric of the number of encounters. Well, at least as related to forecasted, because I can see how much torque the spend has, and whether the variance is like, a healthy variance or not, or and then I can get a sense of how y'all are thinking about it in as much as readapting the spend for next year. I know it's quick and dirty and it's not value based necessarily, but it's still very very encounter and fee for service based. But nonetheless, it would help me get a sense of the torque of the spend.
That's absolutely analysis we do, and mainly going into the budget process, but also on an ongoing basis. There's a lot of complexity in, I think, what you just asked Manager Malwani, in terms of the projections on this page are not always apples to apples. We have physician office visits, and we have surgeries, and we have dialysis, all kind of bundled in. We do have bundled payments as well that are built into this, so we don't want people to draw the wrong conclusions from seeing some of that data on a page. It would be an agenda item, I think, on its own to walk through
that makes sense to me. So yeah, I would either ask to meet, or we could maybe just do a deep dive sometime during the year. So yeah,
That's right.
I think it'd be helpful for an agenda item at whatever interval seems appropriate, because that, and I'm not going to speak to the specific data, but just to help us understand what we're projecting in terms of level of service and what we're getting.
Yes.
So, because that's what I'm hearing, that's what that would tell me, as if I knew the number of encounters we thought we were going to have. In other words, the amount of service we were providing, and how we're tracking against that.
Absolutely.
That'd be helpful.
We have that detail, and we're happy to bring that back.
Okay. All right, Manager Valadez?
This is a very, very simple question, because everything across here is the month of September, FY year to date for 2025, 2025 budget amount used, and then comparing it to the 2024. We're in the 26th fiscal year. So I'm interested in knowing what our 26th fiscal year also looks like, as opposed to everything in 2025 that ended September 30th. So, or the end of September. And to me, it's kind of, for newbies or people who are not accounting experts like myself, it's better data. And for the purposes of explaining.
They might be doing it at the end of the month, and we're not at the end of October yet, as you know.
So we only have one meeting a month.
I see.
And as we only have one meeting a month, we would be getting data a month late. And we're only talking about September, we're in October. So
Yeah.
they should have had, this is all computerized. They should have been able to put that information together. And so all I'm saying is that, I guess I would like to have,
For which period? Fiscal year 26 budget?
yeah, because we're in fiscal year 26.
Yes,
So
I can put
for-
the fiscal year 26 budget in there.
And
just
we're still in
not
October?
actuals yet.
I understand.
Yeah.
I understand, but as we start to develop this kind of process, especially for building efficiencies and looking to see how we can look at the budgets, costs, projections, as we go into this transformative year, it would help us develop better habits. So, thank you.
We'll
Okay.
start bringing FY '26 next month.
Okay, all right,
I have one quick question,
yes.
very quick. I know this might be not particularly relevant, but it's an issue I hear recurrently, and that's with anesthesia. Do we have any, perhaps in that correct discussion right now, to bring anesthesia in-house? As much as our anesthesia is probably done as an outpatient.
I think bringing anesthesia
It
in-house.
might be a closed session kind of conversation.
Okay, thank
Yeah.
you.
Okay, are we ready to move on? Okay, thank y'all very much.
Thank you.
All right, we'll move on to our next item, item number 3. Receive the September 2025 financial statements for community care health centers. Dr. Nick Yagoda will be presenting.
Good evening, everyone. All right. So Joy Sloan is out today, so I will do my best to replicate a small fraction of her brilliance. This is the final monthly report for the FY 2025, which I want to say at the outset, it was a great debt of gratitude to Central Health staff and board for helping with some important early investments in the community care operation to ensure sustainability over the course of the year while we were taking some substantial, undergoing some substantial operational decisions of our own about how to navigate some headwinds from a financial standpoint. So if we go to the next slide, please. We closed the year with what ended up to be a loss of $1.65 million. You may recall, conservatively, we were at one point it would look at $15 million. With the $2.8 million investment that Central Health gave to us earlier in the fiscal year, that took us to somewhere around a $10 million gap to close, conservatively, maybe less if you think from there. And so I wanted to highlight some of the work that, in addition to the $2.8 million investment that Central Health gave us, that we undertook ourselves. First, there was some substantial effort in the pharmacy area to improve margins throughout the year. We, again, with the help of our people department, which did a terrific job helping us onboard more providers than we lost, we saw improvement in productivity. And then we flatlined wages by right-sizing support staff in light of some of our provider vacancies. That was a tough decision, but one that we were able to navigate relatively undisturbed at the front line, but certainly required some gumption on the part of senior leadership, and I owe them a great debt of gratitude to helping us make that choice. Next slide, please. The days cash on hand ended at 38 days. We saw AR increase as we trued up some of the collectibles from the AR balance. Our current ratio, there's a confusing typo in here, cross out increased. Our current ratio slightly decreased because of the current liabilities related to health insurance premiums and also our payables increased. And compared to the prior year, we saw accounts receivable decrease 8.6 million, and we saw current liabilities decrease 4.1 million, while cash itself grew by $3 million. So some improvement of processes helping with our prediction capability. Next slide, please. In 2025, we were slightly above encounters compared to 2024. We expect to exceed that substantially in FY26. We've set ourselves a goal of 600,000 visits next year. We are actively recruiting for open provider positions. We did onboard in the month of September 4 additional providers, 3 in the behavioral health space, 1 physician. We also have more providers in the pipeline to begin and are still actively recruiting for open positions. Our plan, as has stayed the case for the last 6 months or so, is the introduction of an incentive pay structure. We're hoping to get that going at the beginning of the calendar year. Developing strategy with HR for resources for provider relations, to start investing deeper in our relationship with ongoing providers and also building pipelines. And then recruiting increased targeted recruitment for experienced APPs. This is I think there was some discussion about some hard to recruit positions from the specialty mix. Experienced APPs are also a tough to recruit group, and so we're going to have to take some special approaches to that. But we feel like we have a very compelling place to work as to offer for those recruits. Next slide, please. So significant strides made in the last half of the year to help lower what were forecasted to be some substantial operating losses. Again, we had talked at the most conservative estimates to be around 15 million. We thought likely because of the support from Central Health, closer to 8 to 10 to 12 million by the time we were halfway through the year, and we were able to bring that down because of careful consideration on hiring, focused recruitment to fill open positions, some movement of pharmacy to in-house capture, which allows much more reliable revenue from the pharmacy bank, and a tireless effort on our pharmacy department to find other improved margins through 340B, at navigating 340B challenges. And I believe that it should be our last slide.
Okay. Thank you very much. We'll
You're
see
very
if we
welcome.
have any questions. We'll start around this side of the room. Do we have any questions over here? Go ahead.
The question I have has to do with sort of anticipating, which is hard, but anticipating future needs for CUC as it pertains to the number of patients coming through the doors.
Yeah.
I just want your general thoughts on that in terms of what is the thinking, as we know we've got drastic changes with the funding, et cetera, from the feds and so forth. And because of the immigration patterns changing.
Yeah.
What are your thoughts with respect to service delivery in terms of, do you see numbers dropping, less services, need changing?
So we don't see a need changing. First of all, a very good question, and it's front of mind for all of us. There was a really nice article in the New York Times today around the FQHC in Mount Bayou, in Mississippi, the first FQHC in the country. It was nice that they picked out that country to talk about how Medicaid changes are going to impact and make even thinner the margin that FQHCs live on. This was something that we anticipated. We're starting to see it come into reality, at least as projected in that story. We ourselves are not yet experiencing the level of pinch for a number of different reasons. One, we have a fairly diverse revenue source, given a large pharmacy program, a huge partnership with MAP and MAP Basic programs. And we've been able to hold steady on Medicaid thus far. In prior years, we anticipated a return, a rebound of the Medicaid funds, which left us in a little bit of a lurch when it didn't move. This year, we held our Medicaid percentage of the payer mix steady. So with the belief that we have likely seen the erosion that we expect from the Medicare changes, because we didn't have much Medicaid in the first place. That said, So we will not experience what many other Medicaid expansion states will experience, where they'll start seeing more and more uninsured. We've already had the uninsured. And in this case, we're very fortunate to be able to enroll the uninsured into the medical access program. So we're watching it very carefully, our payer mix, we're watching our volumes very carefully. And for the most part, we're not seeing substantial changes, with one exception. It does look like we had a very slight dip in the number of visits for pediatric patients, but not necessarily the total number of patients served. I believe that is the correct stat, but we are watching that very carefully, obviously, because Medicaid, the children, to Dr. Greendyke's beautiful statement before, are the foundation for managing a trajectory of an equitable and dignified life. And they also serve as a very important financial cornerstone for us.
Thank you.
Yeah, great question.
Thank
Shan-
you.
wait, let's go.
I'm sorry, Shango, I'm sorry.
Just two quick questions. One is, do you all have self-pay?
Yes.
Okay, I don't know if you have any data on it. It would be helpful to see what percentage, not now, but at a future time, what percentage are self-pay, and if you can do it by demographics, that would be helpful as well. The second question is, I'd like to thank you and the team for, over this year, absorbing, working with, developing, and helping the Black Men's Health Clinic, which has come a long ways and still has a long ways to go. And so and that first question somewhat relates to that, because I think there's a population that could be benefit from self-pay within that group. But I wanted to acknowledge that here today.
Yeah, thank you very much for highlighting that. We actually had a terrific retreat with some of our executives and their executives about planning the same way we've done so with Central Health and Sendero around what are objectives and key results for this coming year, really getting increasingly focused on the work that we collaborate on together. It's been a great partnership.
Manager Botmani?
Yeah, I just, thank you. Echo, I think what's been said. Words don't really, I think, acknowledge, I think the board and the community's appreciation of community care staff, board, and this board and staff's resilience over the last year. So thank you for that. The encounters are slightly, I guess, slightly above last year. In as much as just, I guess, and forgive me for not having studied this more closely, but in as much as net revenue is concerned, or at least just what the operating loss is, how does that relate to the overall number of encounters? I guess comparatively.
Good question. It's sufficiently nuanced. It has more to do with a combination of the number of encounters and the payer mix of those encounters.
Yeah.
And even layered on top of that, the revenue that's able to be generated based on what type of patient, what payer they have, and therefore what 340B benefit we can get.
Right.
So there have been three interacting forces. One has been the payer mix shift, the 340B regulation changes, and then a provider vacancy gap that we have been slowly closing. So all three have played together to allow us to realize more numbers than we had, because we had grown a workforce to accommodate a larger volume. So we did see improvement there, but not to the level of improvement that we wanted to in terms of total number of visits. We had budgeted for around 600,000 visits, just under 600,000 visits this year. So getting to 527,000 visits is an improvement from last year. It wasn't the improvement we had hoped to see. It's all layered together.
And sort of given those, and thank you for that, given those interacting forces, and I guess what I'm trying to get to is like sort of net revenue per encounter, per sort of metric, and how predictable that can be, if at all, and how much we can sort of cater to what is best ultimately for the patient and sustainability to be able to serve the patient. But if we were to say have had an aggressive number more of encounters, would that have, in sort of maintaining equal the interaction of these three variable forces that you're mentioning, if we would have had more encounters, would that have meant that there would be more of an operating loss Or would that have closed a gap on that loss?
There,
And I know Joey's not here, so it's not fair, but it's, those are things I'm
given
curious.
our average cost per encounter, we would have closed the gap.
Okay.
There are certain payers, MAP historically, although we're now in this coming year going to finance slightly differently, but Medicaid is a good example where the revenue generated versus the cost of that encounter is substantially positive for us. So had we had greater productivity, we would have seen that operating cost close, given our present payer.
All things equal, yeah. Thank you.
Quick question.
Yes.
Thank you for the great work. I really appreciate it. I have a question about cost per encounter. And it kind of went about $35 per patient from 24 to 25. Is there a reason for that? And what do you project? I know it might be complex, but where do you see things going aside from inflation, et cetera?
Inflation is one. So if we're just talking about cost, not net revenue.
Yeah, what's your medical cost per medical encounter? Went from 242 to 279.
Yeah, this largely has to do with inflation. I will research that to see if there's any other drivers, but my understanding is that's largely driven by inflation.
The other question, as Medicare is can be such a large source of income for y'all, is there any advance or movement to recruit more Medicare patients?
Yes.
Okay.
It is part of our larger strategy. Yes.
Thank you.
Okay, Manager Valadez, Manager Rodriguez? No. Okay, we're gonna move on because we are almost an hour late. Do you need to say it? Or can you say it offline? It's up to, if you need to, that's fine. I'm just, we're almost an hour behind.
I would like to check in if I may.
Sure.
Yeah, I just want to acknowledge you did a great job. Joy, be proud. And I appreciate leadership at the helm, Dr. Yugoda. Thank you.
That was great. That was nice and succinct. Thank you. So, okay, we're going to move on now. Thank you very much. Okay, we are going to move into closed session now. For items 4A, 4B, 4C, and 4D. Let's see. Which are discuss and take appropriate action on 4A is acquisition of 2 properties located in North and East Travis County. 4B is adoption of a resolution approving the issuance of the district's COs and requesting that the Travis County Commissioners Court approve and adopt orders to authorize the issuance of such certificates and other related actions. 4C is adoption of a resolution expressing intent to finance expenditures to be incurred. And 4D is approval of a central health capital project budget. So agenda items 4A and 4C are under Texas Government Code Section 551.071, consultation with attorney, and Texas Government Code Section 551.072, deliberation regarding real property. And then agenda item 4B and 4D are under Texas Government Code Section 551.071, consultation with attorney. Okay,
Chair,
it is now.
Chair, it's 5:20. We do have our last person for public communication here. Did you want to just take that before closed session?
Yeah, I guess we better do that. Okay. All right, so do I have to read all this over again? Okay, scratch that, or suspend that, and we will take, thank you for interrupting me to let me know that I wasn't noticing that, so let's go ahead.
Okay, thank you, Chair. We have Sonia Burns, who's joining us here in person, and I will pull up the public communication guidelines.
Chair Kitchen, you might want to recess BNF and then go into Board of Managers so you can, because I believe all of these commenters are for the LPPF.
Okay.
So you can do that public hearing.
Oh,
knock
are
that
they?
out.
Okay. All right, so I'm going to recess the Budget and Finance Committee, and I'm going to open up the Board of Managers.
Oh, I apologize. I thought those were the LPPF commenters. Is it just one? That's the general public comment? Okay.
Okay, so
Sorry,
we don't need to recess. We're going to stay
Yeah,
in Budget and
that's
Finance. Okay, thank you. Come on up. It's okay. Come on up.
Thank you, Sonia. When called upon to speak, please introduce
You're
yourself.
more than welcome, Sonia. Just go ahead.
Please introduce yourself by name before beginning your comments. Also, if your comments will focus on a specific item or issue on the agenda, please indicate the full item number after your introduction. Each speaker will be limited to 3 minutes. Staff will be timing each speaker. We'll announce when the speaker has reached their limit. To ensure the efficiency of the meeting, once we've let speakers know they've reached their limit, we'll allow 30 more seconds to wrap up comments. Due to the restrictions of the Open Meetings Act, the board may be restricted in discussing any items that are not listed on the agenda for this meeting. The board may choose to set aside any new issues for discussion at a later meeting. Sonia, you have 3 minutes. Thank you so much.
Okay, can you hear me? Did I hit the right button? Yeah,
Yes.
I did. Okay, hi,
You're
I'm Sonia
good.
Burns, just myself. And since you're talking money, I'm just gonna talk about something that we are not capturing in any of our expenses. So, and I would make a recommendation that this board, and I know you had your joint meeting with Integral Care, you all really do need to hear from the mental health public defender, the county attorney, the district attorney who handle the MH, mental health and IDD dockets. They are using all these services. We are seeing people go round and round. Last session, I got a bill through Charles Perry, Senator Perry, SB 1677, which included a state auditor's report on competency restoration services, because we always hear about the gap in continuum of care. And if you look at the competency restoration wait list, all these people in jail, how did they magically meet inpatient criteria behind the bars of a county jail cell and not out here? But what we saw was, in a 5-year look back, we had the state auditor do it. There were over 15,000 people in Texas placed on the competency restoration wait list. 1,528 came back repeatedly with new charges. So anybody doing this work knows this is a higher needs population. Travis County was second only to Dallas. So 808 people in Dallas. We had 676 unique individuals coming back multiple times. Many of them had done competency before. HHSC, in all their wisdom, got a grant through the BJA and gave us forensic navigators, so we don't have to put you on the list when you go to jail. We will connect you to services to what? We have a higher needs population. So I got a rider this session through Perry, working also with Senator Colcourse, Chair of Health and Human Services in the Senate, Rider 56. So this is a study for a pilot to address that gap population that needs something in between hospital level care and community placement. I said this when I was here last time. I do often feel like I'm treated like the village idiot in Travis County. I have been working on this forever. Harris County meets with me, a standing meeting every month to go over this, to collect the appropriate data. And we are not capturing this population, and we could be at the forefront. We have state troopers clearing our encampments right now. We have School for the Deaf, School for the Blind, State Supported Living Center, State Hospital, UT Flagship, medical school, law school, social work, education. There is no reason that we are not getting this done. So I need all of you to work with me on this rider, because this Austin State Hospital was a bullshit thing we did that is not touching the group of people it was meant to serve. It's all on the back end of a carceral system, competency restoration, biggest waste of money and time we've ever done. So I need you all to know the right questions when you're working with Integral Care. I will be putting together an email and sending it to you all. Feel free to ask me questions. But one more thing, we talked about Medicare. Nobody in the country is collecting this data point, and it's ridiculous. Under Medicaid, I can only get 15 consecutive days per month of inpatient psychiatric care if it's a facility of 16 or more beds. When I am so sick, I could be 26 years old, and I now am dual eligible for Medicare as well. Medicare doesn't care the size now. I have 190 days, lifetime limit of inpatient psychiatric care. I got a benefit because I was so sick I needed it, and now I've left you unfunded. So that's why you need a state hospital system. We should be collecting that. It is not going to lead to more inpatient care, I do not believe. That will turn into a housing subsidy, because these people are seriously deteriorated and need a different level of a residential option that we don't have. So there, and then you mentioned children, look at TJJD. If you haven't read the DOJ report that came out a year ago, read it. They're all IDD, autism. It's terrible. Our CWAP kids in the foster care system, only at the beginning of this session did HHSC finally admit children without placement in the foster care system, almost all of them have a comorbidity of IDD or serious autism. And the LMHAs and the LIDAs know it.
Thank you for joining us. I appreciate that. We will follow up. Okay, I'm going to now move us into closed session. The time is, it's October 22nd, the time is 5:23. We'll go into, it's probably too early for food. Is there food out there? Too early? Are we ready? Okay, the time, it's October 22nd, the time is 7:05, and we are back in open session, and we're on item number 4. I'm going to make a motion on item number 4A, which relates to the Northview property. I move that the committee recommend that the board approve the acquisition of the property located in North Travis County on terms similar to or better than those discussed in closed session. And members, this is the Northview property. All in favor?
Aye.
Okay.
Do we need a second?
Yes, so we need a second.
I'll second.
Second, okay, all in favor of the Northview property? Okay.
Aye.
Somebody counting? David, are you counting? Okay, all opposed? Okay, any abstentions? Okay, I think that one passed. If someone would like to make a motion on B, which is promontory,
I make a motion.
okay,
I move the committee recommend that the board adopt a resolution approving the issuance of the district's.
No,
Okay, right, this one, okay, I apologize, okay. I move that the committee recommend that the board approve the acquisition of the property located in eastern Travis County on terms similar to or better than those discussed in closed session.
second, all in favor?
Aye.
It's 5. Got it, David? All opposed? Okay, got it. I don't think we had any abstentions, right? Any abstentions? Nope, okay. The second was Dr. Martin. Okay, well, now we'll go on to item number C. This one is issuance of the COs. I'm sorry. B. I'm sorry. Item B. Would someone like to make a motion on item B?
I will. I move that the committee recommend that the board adopt a resolution approving the issuance of the district's certificates of obligation and requesting that the Travis County Commissioners Court authorize the issuance of such certificates.
Second?
Second.
Second? Okay, let's
Chair
see.
Kitchen, can I have a point of clarification?
Yes.
Just for sequence. So if we vote on this issuance of certificate obligation, is this the last time that the Central Health Board will have an opportunity to vote, or is there another vote coming around issuing, or is this
This is
it?
it.
And we're delegating authority to the Central Health
Yeah.
Administration?
That's
to-
my understanding. Because we had some votes to go down the road towards this. It was notification we sent out and that kind of stuff. My understanding, and tell me if I've got it wrong, but my understanding is this is the final vote on this,
For this board,
for the issuing the COs.
for this board. It must go to the commission.
Well, yeah, you're right, I'm sorry.
But there's no other vote coming to us
Right.
for anything more.
That's right.
This is the final vote.
That's right. Okay,
I have a question, just a clarifying question.
okay.
Does this mean then that if we approve these certificates of obligation for any of these two buildings that we're talking about, does that then mean that that's the final time that the staff's gonna come to us asking us for more money? Or does that still leave the window open for them to come back and ask for more?
They can ask for more money if they need more money.
This is for the acquisition.
Okay.
Yeah.
Okay.
And this, if my understanding is item number B is for all 4 properties. It's the COs related to all 4 properties, the 2 that are existing that will go from cash to debt, and then the 2 new ones.
And then one just additional point of clarification. The motion is up to $290
That's right.
million. It doesn't mean they're going to have,
That's right.
they are required to issue all of that debt.
That's right. It's
Okay.
just a maximum amount.
Okay, I need clarification. So you're saying that, I want to understand that the motion on B, that motion that we just did,
Yeah,
that's for all 4 properties?
that's right. So A1 and 2 was about
The new
purchasing the properties. B is how we pay for it.
Right, okay.
So, and B currently, as written, it's the COs related to all 4 properties. I mean, we can separate it out if someone wants that, but it's written as all 4.
Well, since it's written as all 4, I can only speak for myself. I'm prepared to support the certificates of obligation. Oh, no, the other has to do with a cash
It's still a CO.
Okay, well, I'm prepared to support the existing projects, but I'm not
Let's break this
prepared
up.
to
Let's break it into
support.
two. Let's break it into two.
Okay.
So that you can have that vote. So, yeah, so we're gonna break it into two so you can have that vote. If, I can't remember who made that motion, if you'll let me. Let's take first, I move that the committee recommend that the board adopt a resolution approving the issuance of the district's certificates of obligation related to the two existing properties. Can I just say it that way? That we're moving from cash to debt. Y'all know? Yeah, can we just say it that way? Okay. So that's the first vote. That's what's on the table in front of us now. And is that, whoever made that second, is that okay?
Yes.
Okay. All right. All in favor?
Aye.
Okay. You got it?
Lisa, did you say you wanted to support?
Okay. Anyone opposed?
Yeah, I'm all confused now, so I don't.
Opposed?
Do you want me to, what we're voting on right now is the COs for the two existing properties, which means moving the two existing properties from
Cash to
cash to debt. So if
Okay.
you're in favor of that, you'll be voting yes on
Okay,
this.
I want to vote yes for that. I'll vote for that.
Okay, so we got all our
Sorry.
yeses?
Yes.
Thank you.
Okay, any no's? Okay, one no. I'm holding up for voter approval. That's okay. It's,
Yes, I did. Yes.
yeah, okay. Okay, so now our next vote is, I move that the committee recommend that the board adopt a resolution approving the issuance of the district's certificates of obligation related to the proposed two new properties that includes Northview and Promontory.
Okay, that's a second.
You've got a second for that. All in favor of that one?
Aye.
Got it? Okay. Those opposed? Okay. Got it? Okay. The next motion is, I move that the committee recommend that the board approve a resolution expressing intent to reimburse expenditures to be incurred in the issuance of the certificates of obligation.
I second.
Now, this one's not broken up either. Well,
Does
okay.
it matter really?
I don't know if that one
I don't think
matters.
it matters.
That one doesn't matter. Okay. Yeah, okay. All right, so we have a motion, a second?
Yes.
All in favor of C?
Aye.
Okay. All opposed? Okay. Did you catch that, David? Okay, now we're going to go on to item number D. I move that the committee recommend that the board approve the capital project budgets as presented by staff. Now, these budgets are for both, Promontory and Northview.
That's correct.
So, I'm going to break them up just for clarity. I move that the committee recommend that the board approve the capital project budget as it relates to Northview as presented by staff. All in favor?
Second first. I second.
Second, all in favor? This is Northview. Okay?
Aye.
All opposed? Okay. Now I'm going to move that the committee recommend that the board approve the capital project budgets for Promontory Point as presented by staff. All in favor?
Second.
All opposed? Okay. Holding out for voter approval. Okay. All right, so we have completed that. I would like to make one very quick statement since we're now in the public, an explanation of my vote. I support, the reason I voted no on Promontory Point, and I would like the public to understand this, is because of the timing. I am concerned that the timing is not appropriate because I feel like we don't yet have a complete capital budget master plan, and because the purchase involves a greater space than we need right now, understanding that there's an interest in growing. So at this point in time, I felt like it was not appropriate because of the impact it'll have on the public, and it's a timing issue for me. So. Okay. So we're gonna, yes.
Then I would like to say that the reason I did not support these is because we don't have a facilities plan in place. We don't have a capital projects plan in place. We were left without total information that we as board members had asked for. And this is not, this vote is occurring without a voter referendum, and I think it's important that the public know exactly what the plans for Central Health are, not only in the short term, but in the long term, and they do not know that yet.
Well, I may as well tell the public why I said no, too. I basically said no for the very reasons that Chair Kitchen articulated, as well as Cynthia, Manager Valadez. But in addition to that, I think it's really important that we be very good stewards of the public dollar. And I'm not sure, in light of the fact that we didn't have all the information that we needed to make this decision, and it's not for a lack of staff not doing their job, that the staff did a great job. It just means that I didn't feel like we were yet ready to make a decision like that. And so for me, trying to be a good steward of the public dollar was primarily the reason why I voted against it.
Okay. So I really don't want to take the time for everyone to explain their vote.
Okay, well, you did.
I did because I voted no, and this passed. And
Okay.
so having
All
your
right.
vote no. But if you want to say, go ahead.
Well, the reason I say I did, because of the implications, we're not being financial stewards, those who voted yes. And
Okay, go right ahead.
so I would disagree. I think the data strongly supports the need for this.
Okay.
The hospital is a moving subject. The district is a moving subject. No one has a crystal ball. We have been empowered by the citizens to make these decisions. We don't have to take everything to a proposition to raise debt. They've committed to us to be on this, and I think we're just doing our job. Thank
Okay. All right. I'm going to move on. Okay. All right. So we're going to postpone item number 5. In the interest of time, we'll move on to item number 6, which is confirm the next Budget and Finance Committee meeting date, time, and location. Our next Budget and Finance Committee is scheduled for Wednesday, November 19th at 2:30. So at this time, I'm ready to accept a motion for adjournment. So moved. Second? Yes. Okay. Okay. All in favor? Aye. Okay, now don't go anywhere. We have a board meeting.
You want to stay here?
We have a board meeting. And we're moving directly into our board meeting right now. So, okay. Let me see if I can find where's my script for the board meeting? Don't do this now. I got to get started. Do we have our script for our board meeting? Okay. Okay. All right. Good evening. Today is October 22nd, and the time is 7:18. As a quorum of the board is in attendance, I'd like to call to order the meeting of the Central Health Board of Managers. We've already taken care of public communication, I think. Yeah. So the first item of business is the consent agenda. So we are taking items. Oh, sorry. Okay. All right. All right. So this evening's hearing is the official. All right. We have a public hearing tonight, y'all, that we do have to do. Okay, and we're now going to proceed to the public hearing. This evening's hearing is the official public hearing for the annual LPPF rate setting required by the Texas Health and Safety Code. Notice of this evening's public hearing was published as required by statute. The hearing will begin with staff's presentation of the proposed annual mandatory payment rate. At the conclusion of the presentation, we'll invite comments from the public. And to make comments during the public hearing, members of the public must either be physically present at the Central Health Administrative Offices or have registered with Central Health via the online form or by telephone no later than 2:30 p.m. today. Okay, so we're going to, the hearing is to receive public comment on the proposed mandatory payment rate to be assessed on institutional healthcare providers during fiscal year 2029 under the LPPF, the Local Healthcare Provider Participation Program in Travis County, and how the revenue derived from those payments is to be spent, as required by Texas Health and Safety Code, Section 298E.101. So Katie, if you want to present for us.
Thank you, Chair. The Local Provider Participation Fund, or LPPF, is the mechanism by which this board assesses a mandatory fee on inpatient hospitals in Travis County, and then uses those funds as the local match to draw down federal supplemental payments. We can go through the presentation. There are 3 slides. It is the same you've seen every year, so I won't go over it unless you have questions. I will say that in a consultation with the hospitals in the county, the staff is recommending we set the rate at 6% for FY26. But if you want to advance so you can see. So this is the general information about how the fund works, so that we hold the funds in a fiduciary capacity and use it only for approved purposes, and we recommend 6% for this year.
Okay. Any question? Do we have any public comment on the?
We had one speaker before.
Yeah, that's right, but do we have any
and
now?
he spoke in favor of the 6% rate. I don't believe we have any other comments.
I'm not seeing any questions, so I'm ready to take a motion to close the public hearing. Manager Valadez, second.
I move that the Central Health close the LPPF public hearing.
Okay, do I have a second? Second from Manager Martin. All in favor?
Aye.
Okay, public hearing is closed. So now we're going to proceed. Yes.
If I would just note that I'm abstaining from this particular vote, so thank you.
Okay. Okay, we are moving now, we don't have any public communications, so we're moving to the consent agenda. And the consent agenda includes everything except for C9. C9 was an open-ended in case there was any recommendations on key issues related to the co-applicant agreement from the CUC Liaison Committee last night, and there weren't any. So we're doing C1 through C8. Could I have a motion to approve the consent agenda?
I move that we approve the consent agenda from C1 to C8.
Okay, second? Second. Okay, all in favor? Aye. Okay. All right, now we're going to move. Okay, one abstention? Okay. 2 abstentions. Yeah. You can abstain if you want.
I'm going to abstain.
Okay, we have 3 abstentions. Okay. So we have 3 abstentions and 5 passing it. Okay? All right, so we're moving on now. Did you get what you needed, David? Okay. Now we're moving on to the regular agenda. The first action item is to take action on the LPPF rate. So, which we just had a public hearing on. Would anyone like to make a motion to approve the LPPF rate of 6%?
I move that the board approve the fiscal year 2026 LPPF mandatory payment rate at 6% of net patient revenue as recommended by staff.
Second? Second. Okay, Manager Martin. All in favor?
Aye.
Okay, that passes unanimously. Okay.
Oh,
wait.
Yeah,
But one abstention. Yeah. Sorry, I should have noted that before. All right, so now, okay, so managers, let's think about this. It's 7:24. What I would suggest, action items. I think we should go into. I would like for us to go into closed session right now because I think we have a presentation that needs to be made. So we're going to go into closed session right now, and we'll come back if we have time for these. We'll come back if we have time for these other matters. because it's 7:30 already.
You have to articulate the item though?
Yeah.
Yes, okay. So I'm going to read items 4, 5, 6, and 7.
Can I make a special request? We could have 10 minutes to share a reflection on FY25. The staff has worked very hard to
No,
prepare.
you can do that when we come back. It is 7:25. We've got important things to discuss in closed session. When we come back out, we can do that. Every minute that we do this now takes away from the conversation, which I know is very important to you and to the rest of us in closed session. So we're going to go into closed session. So item number 4 is to review and discuss. Well, actually, I think that we can postpone item number 4, and item number 5 is the main thing that we need to take. Item number 6, there's nothing for, and item number 7, there's nothing for. So, okay, so we're going in on item number 5. So, I announce that the board is convening in closed session to discuss item number 5, receive and discuss a briefing regarding Travis County Healthcare District DBA Central Health versus Ascension, Texas, FKA Seton Healthcare Family. So we're going to go and let's see, we're going into agenda item number 5 under Texas Government Code Section 551.071, consultation with attorney. So I don't know if that's.
Date and time, and then we're done.
Yeah.
Date and time, and then.
The time is, it's October 22nd, the time is 7:26.
Do I need to announce it? Pursuant to my conflict of interest disclosure form, I'm going to be not attending the executive session
Right.
on the matter that you just described.
Okay,
Yeah.
thank you. Okay, thank you. Yeah. ready? Okay, we're coming, okay. It's October 22nd, the time is 8:46, and we're entering open session. So, managers, I'm going to close out the Board of Managers meeting because, and let me tell you why. Item number 3 relates to our upcoming board meetings. There's information and backup. I'd invite y'all to read them and see if there's anything you'd like to add, and then we'll also discuss it at our next opportunity. Item number 2, the information is in backup, Dr. Lee, I think. And I know you want to go over it. It is 8:46. You do not have your managers at their best level of listening at this point. So I would suggest that let's set a time as soon as we can so you can go over it and we can I mean, it's very important, these accomplishments for the last year. And I personally want to be in a position where I can really hear them, and I just don't think we're there at the moment.
And to that point, it's really important because, let's face it, we're in the middle of an evaluation period.
That's right. So
we
let
really
us,
gotta hear
plus
from
you
them.
don't have all of us here. It's much better to when we have all of us here and we'll go over it. So, all right, so I'm going to move us on to last item, confirm the next regular board meeting date, time, and location. Our next Central Health Board of Managers meeting is tentatively scheduled for Wednesday, November 19th at 2:30. At this time, I'm ready to accept a motion for adjournment.
So moved.
So moved. Okay, don't all at once. Manager Valadez, then Manager Brinson. All right, we're closed. Okay, thank you all very much.